We've heard a lot about the concept of shared decision-making in several cardiology guidelines, recent clinical trials, and even related to Medicare coverage. So what is shared decision-making anyway? Well, it's a two-way exchange of information between you and your patient. When there are multiple treatment options, and especially when there is clinical equipoise, you both have information that's essential to a decision. As doctors, we have expertise about the patient's condition, the clinically appropriate treatment options, and their associated risks, benefits, and trade-offs. In hearing this information, patients may place different values on the risks and benefits of treatment. They may want to add some of their hopes and fears to the risk-benefit equation. Ultimately, the patient needs to make a decision that agrees with what feels right for them. Therefore, your clinical expertise is most effective when it's combined with a solid understanding of the patient's preferences, lifestyle, and goals. So who has time for this? We all went to medical school. We all read up on the latest guidelines and clinical trials. So we can have the answers and know what's best for our patients. And if you're like me, we spend a lot of time talking to our patients about their conditions and the treatment. After hearing the information, many patients ask, "Doc, what would you do?" Clearly, we all want to do what is best for the patient. Often, that usually looks a lot like this.
Dr. Miller, I'm not sure I completely understand this heart problem.
Well, atrial fibrillation is a very common heart condition. It can cause a thromboembolism, which can cause a stroke.
A stroke?
Yeah, atrial fibrillation is one of the most common causes of stroke. And yeah, in someone with your comorbidities, your risk of stroke is high. We should get you started on an anticoagulant right away.
That's a blood thinner, right?
That's right. There's an old one called warfarin, and there are some new ones called direct oral anticoagulants like apixaban, rivaroxaban, edoxaban, dabigatran. And your risk is high. You should be on one of these. Most people prefer these newer ones because the old warfarin, you have to monitor your blood levels, watch your diet, and the new ones, you don't have to do that. And we think these new ones are a little less likely to cause bleeding than warfarin, so I think we should get you started on one of those right away.
Oh, okay.
Pretty typical conversation, right? The doctor explained the condition, the options for treatment, the pros and cons, and the patients seem to go along with the plan. I have these conversations with patients all the time. But is it really shared decision-making? Maybe not. Let's watch another scenario.
Hi, Dr. Miller.
Hi, Ellen. I see you have the information on atrial fibrillation there. Have you had a chance to take a look at it?
Yes. I know AFib makes it more likely that a blood clot can form in my heart, travel to my brain, and cause a stroke.
That's right. Is it okay if we talk about some of the options to lower your risk of stroke, and then we can decide together what's right for you?
Yes.
So there are several medications that can lower your risk of stroke. These are all different types of blood thinners. For someone with your risk, we can lower your risk of a stroke from about 6 in 100 per year down to about 2 in 100 per year. Do these medicines sound like they might be an option for you?
I'm a little concerned. You said blood thinner? I had a bleeding ulcer a couple of years ago, and that was not fun.
That's a great point. All of these medicines do increase your risk of bleeding. And the decision to take one of these medicines is really about the trade-off between lowering your risk of stroke on one hand and that risk of bleeding on the other hand. If you do decide to take one of these medicines, then we would want to watch closely for signs of bleeding.
I'm not sure, Doc. What do you think?
Well, I'm happy to make a recommendation, but before I do, let me understand just a little more about what's important to you. What do you think about the prospect of taking one of these medicines every day for the rest of your life?
Well, I definitely don't want a stroke, and I don't love medications, but I'll take them if they'll help me.
Well, in that case, I do think it would be reasonable to take one of these medicines. We can review all of the causes and symptoms of bleeding to make sure you're able to watch out for those.
Yeah, that should be good.
All right, well, let's get started on one of these medicines. And then if it's not going well over time, we can always have a discussion again and talk about other options.
That sounds great.
Did you see the difference in that conversation? You're already good at explaining things to your patients. This is just a small next step to ask and listen to what matters to them, and then incorporate it into the decisions you make together. Shared decision-making is an intimate conversation between you and your patient. It improves accuracy of patients' risk perceptions and expected benefits. It also improves provider satisfaction. And there are tools to help you have this conversation faster and better. The ACC's evidence-based tools are available online. Patients can use them before or after a visit, or you can use them during a visit. I highly encourage you to use shared decision-making in your next conversation with your patient. To learn more, go to cardiosmart.org/decision aids.